Hi, this is Dr. Mirski, professor of anesthesiology and critical care medicine at Johns Hopkins Medicine in Baltimore, Maryland. And today I want to give a brief tutorial on acute versus chronic hyponatremia. Where is the limit? I want to preface this by saying I don't have any disclosures related to this specific talk. The fundamental physiology of sodium is encompassed by two primary roles that sodium plays. It is a vital intracellular and extracellular compartment control mechanism, and it supports the membrane potentials of neurons that is vital for neuronal depolarization. It's important to remember that sodium as a solute helps to define water gradients between compartments in our body, particularly the plasma, the interstitial tissue, and including brain. Now, plasma and the interstitium equilibrate over time because they have what we call fenestrated endothelium, incomplete barriers between the fluid in the bloodstream and in the interstitial fluid compartment. Whereas the blood-brain barrier, of course, is a solid wall effectively to sodium. And although fundamentally sodium is high in concentration in plasma and less in brain, hence the Nernst equation for a voltage gradient in the neurons. And the brain osmolarity is, of course, important in determining cerebral volume and hence ICP as it occurs in pathological states. So control of sodium is vital to normal homeostasis and preservation of neuronal function. Now, assuming euvolemia, serum osmolarity is very tightly controlled. Plasma compartment control actually overrides the normal sodium range, which is given here before you. So that means that under normal circumstances, our cells greatly regulate and control their volume to sort of maintain its normal cellular functions. So hyponatremia and hypernatremia can actually be non-pathologic, meaning that they can be normal responses to non-euvolemic states or alterations in serum osmolarity like pseudohyponatremia. Here is a nice electron micrograph of fenestrated endothelium between the lumen of a capillary and the interstitial compartment. And you see these nice little gaps here. This allows flow of water and electrolytes to flow according to their gradients between two compartments. Here, however, is an electron micrograph of a tight junction endothelium as occurs in most regions of brain. And you actually see pores here which greatly regulate the flow, not just of electrolytes, but also even of water. Now, the main purpose of our talk here is to find the difference between acute and chronic hyponatremia and the reason why it's important. Now, we know that normally hyponatremia is defined typically at levels below a serum sodium of 134 or 135, in that range. And we define acute as less than 4 days duration. And the big question is why, and we'll get to that in a moment. Now, the etiologies of acute hyponatremia are varied. There can be simple dilutional free water intake, like a marathon runner taking on water and losing sodium through sweat, and they develop severe or potentially hyponatremia. Transient ADH secretion occurs in numerous states, including some hospital-acquired areas, for example, acutely postoperative states, or just regular stress. And then there comes a syndrome of inappropriate ADH secretion, which occurs under very numerous etiologies, which we won't get into today, but mind you, they are very important in the presentation of acute versus hyponatremia. Now, what happens when we have, particularly in brain, where the neuronal function is so dependent on sodium and much of the pathologies of changing serum sodium occur? If you have a hyponatremic extracellular matrix occur acutely, what happens with a typical cell is that it will initially swell due to the inrush of water because of the hyponatremic and hypoosmolar extracellular matrix. But because cells regulate their volume very carefully, what happens over a few minutes to hours is sodium is actually extruded via two primary pathways, a vascular exchange pathway into the capillaries and a CSF exchange pathway into the interstitial matrix. The end result, however, is to maintain cell volume as it was before, and so sodium is lost. If in this acute situation, we now return back to an isotonic matrix, the pathway is simply reversed, and sodium will regulate itself inward to maintain volume, and so it will replenish itself and no harm done. There is no pathologic response here. Now, if you maintain a cell in a hyponatremic or hypernatremic, doesn't matter, if it's a change in osmolarity that happens and maintained over time, the cell will continue to regulate its cell volume, but rather than rely on electrolyte changes as the only mechanism to maintain its volume, the cell will gain or lose what we call organic osmolytes, which in most cases is represented by myoinositol and other amino acids. These are obviously synthesized by the cell and hence take several days to regulate itself because down and up regulation of protein synthesis is relatively slow. It is well recognized with some very nice experimental data that if you perturb a cell by placing it in a chronic hyponatremic environment, in the first 2 days, most of the changes occurring to maintain cell volume occur by electrolyte loss, and only about 20-25% is due to the loss of organic osmolytes. However, if you maintain the cell in a chronic hyponatremic environment, there is a final adaptation that occurs over time where more organic osmolytes are lost and less of the decrease of osmotic load is due to electrolytes. And you can see the data here that shows a nice loss of sodium, chloride, and potassium in the chronic hyponatremic state, but also a loss of myoinositol, glutamate, glutamine, taurine, etc. So now you have a chronic hyponatremic state, and we're going to correct it one of two ways. First, the acute correction, we're going to talk about the slow correction first, then we'll talk about the acute correction. If you start with a cell here on the right, and it is in a chronic hyponatremic environment, and now you're changing it back to an isotonic extracellular matrix, then if you take your time, and this occurs over days to a week or more, you are allowing the pathway of synthesis of organic osmolytes intercellularly to help accommodate for the necessary change in osmotic tension within the cell. And hence what happens is greater fraction of organic osmolyte is occurring here, and a gradual return of cellular potassium towards normalcy to maintain cell volume. But you have a contribution of each of these osmotic loads. If, however, you have acute correction of a chronic hyponatremic state, you do not offer time for organic osmolytes to be part of this recovery. And you have then relying only on the electrolyte pathway, and so more sodium enters in the cell in an attempt to maintain cell volume. So this rapid influx ends up leading to a higher proportion of sodium entry than originally would have happened in a chronic recovery state. So this rapid correction is what leads to what we call central pontine myolysis syndrome. Investigators are still poring over data as to why exactly it happens and why it happens in this particular locations, but the gist of the data strongly support that it is a high ion to organic osmolyte ratio intracellularly. There's the rapid cell shrinkage that occurs acutely with rapid correction. There's suggestion that the rapid and large increase influx of sodium may create ion-induced injury. The net result of all of these is a triggering of apoptosis. Here you have two MRIs which very nicely show under flare and T2 conditions the pontine myelinolysis syndrome, which causes the loss of myelin of oligodendrocytes, particularly prominently in the pons. We do have other evidence in many patients that this oligodendrocyte myelin loss is not restricted solely to the pons, as you see down here, but also to extrapontine structures, notably around the thalamus, paramedian areas. It's not clear exactly why these are targeted in CPM, but its suggestion is that maybe the density of myelin structures there, of oligodendrocytes, and the ratio of blood flow to extracellular matrix in those regions, and how the shifting of solute occurs, and the vulnerability of the oligodendrocytes. Needless to say, however, these are the common areas that are affected. Here again is an MRI showing two different sequences, DWI, diffuse weighted images in these dark ones, occurring over time of 1 to 4 weeks, showing that you have initial presentation over the first week or so in the pons in particular, and then gradual loss of intensity. In the flare images, you see actually a continued presentation of the CPM pathology. There's no particular treatment once CPM has definitively occurred. In terms of prevention, obviously gradual correction is the mainstay of prevention. Some investigators in the laboratory have data that shows that if you actually help sustain the correction with more organic osmolytes, such as myo-inositol, there is suggestion that that may help prevent CPM in animal models who are then corrected quickly with regards to their hyponatremic state. There is some suggestion even in the clinical world on the left side, patients who are at risk for CPM often are ones who have their plasma exchanged rapidly, such as uremic patients. And there's some case series data, case reports suggesting that uremia may actually prevent osmotic demyelination under certain circumstances. But of course, hemodialysis, in particular in patients with renal failure, is one of the risk factors for CPM. So it's not clear if it's really helpful in a clinical situation. For prevention, then, we want to make sure that we correct serum sodium very carefully, slowly, and typically 4 days of hyponatremic state is considered to have changed that patient over to the chronic state and vulnerable to CPM. And these are some of the replacement protocol recommendations. It has changed over the last 10 to 20 years. Mind you, most of the data now would suggest no more than 4 to 10 milliequivalents per 24 hours. You can use hypertonic sodium if overcorrection is occurring briefly. And urea, not myo-inositol, has been used in tandem with sodium actually as a possibility. So thank you very much for this opportunity to show you this brief tutorial.